Today, we unravel a compelling medical mystery, the case of a 54-year-old woman whose body whispered fatigue until her heart cried for help. Our patient presented with a 2-month history of progressive fatigue, dyspnea, and noticeable swelling in her ankles and face. She also reported cognitive slowing, a subtle but significant change in her mental acuity. 3 days before her admission, her condition acutely worsened, marked by the sudden onset of chest tightness and lightheadedness. Upon arrival, her physical examination revealed a pale, puffy appearance, and she was notably slow to respond to stimuli. Her vital signs were concerning: blood pressure at 88/60 millimeter of mercury, a heart rate of 58 beats per minute, respiratory rate of 24, and oxygen saturation at 95% on room air. Further examination showed distended neck veins and muffled heart sounds, yet her lungs remained surprisingly clear. An electrocardiogram, or ECG, revealed low-voltage QRS complexes with electrical alternans, a classic sign suggesting a swinging heart within a fluid-filled sac. These findings immediately raised suspicion for pericardial tamponade, a critical condition where fluid accumulation around the heart impairs its function. Bedside echocardiography confirmed a large circumferential pericardial effusion measuring 2.2 centimeters, with clear signs of right-sided chamber collapse. It also showed marked respiratory variation in mitral inflow, further solidifying the diagnosis of tamponade physiology. To alleviate the life-threatening pressure, an immediate pericardiocentesis was performed. This procedure successfully drained 900 milliliters of clear, straw-colored fluid, and her blood pressure promptly rose to a stable level. Analysis of the pericardial fluid revealed a protein level of 4.8 grams per deciliter and mildly elevated LDH. Crucially, cytology was negative, ADA was normal, and no organisms were found, effectively ruling out infectious or malignant causes. Despite the immediate relief and initial fluid analysis, the underlying etiology remained a mystery, prompting a broader diagnostic search. The expanded differential diagnosis for pericardial effusion and tamponade is vast, encompassing infections like viral, bacterial, tuberculosis, and fungal. It also includes autoimmune diseases, various malignancies, uremia, trauma, and complications from cardiac surgery. However, the absence of fever, elevated white blood cell count, and the negative cytology made many of these less likely in our patient's case. Then, a few hours later, the lab delivered the clincher, a TSH level of 186 milli-international units per liter and undetectable free T4. This dramatic revelation pointed to severe primary hypothyroidism, specifically myxedema heart, as the true underlying cause of her large pericardial effusion and cardiac tamponade. Hypothyroidism is a known cause of pericardial effusion, though tamponade is less common, highlighting the insidious nature of this condition. The pathophysiology involves increased permeability of epicardial vessels and decreased lymphatic drainage of albumin, leading to fluid accumulation. This case offers crucial insights and key takeaways for medical professionals. First, always consider hypothyroidism when encountering tamponade without tachycardia, as bradycardia is a hallmark of the disease. Second, the combination of low-voltage ECG and electrical alternans is a strong indicator of a large, mobile effusion. Third, clear, protein-rich pericardial fluid is characteristic of a myxedema pericardial effusion, a crucial diagnostic clue. Fourth, always remember to check TSH levels in patients presenting with large effusions, as early diagnosis is paramount. Finally, the management principle is to drain first to relieve tamponade, then replace thyroid hormone to treat the underlying cause. Myxedema heart disease, a consequence of severe hypothyroidism, is characterized by bradycardia, pericardial effusion, and specific ECG changes. The slow accumulation of fluid in myxedema often allows the pericardium to stretch, preventing tamponade, but when it occurs, it can be life-threatening. Untreated hypothyroidism can lead to severe complications, including heart attack, heart failure, kidney problems, and even myxedema coma, a medical emergency. This case powerfully illustrates that in medicine, sometimes the most dramatic cries for help come from the quietest systems. As the closing reflection states, in this patient, every system whispered its fatigue until the pericardium cried for help. The cure lay not in the needle alone, but in restoring the silent thyroid that had stilled her heart.